Imagine for a moment the incredible complexity of your eye. I mean, not just its intricate lenses and nerves, but also that sophisticated bony fortress it calls home. What happens when that fortress, the one built to protect our most vital sense, is breached? It's a question that really blends anatomy, biomechanics, and frankly, the remarkable artistry of modern medicine.
It absolutely does. It's a fascinating intersection.
So today we're taking a deep dive into the complex world of orbital and ocular trauma. We'll be drawing heavily from some detailed insights by experts like Deepak Krishnan and Mark Ox.
Yes, their work provides a great foundation for understanding this.
And our mission here is really to give you a shortcut to being well-informed. We want to explore the eye's protective structures, understand the types of injuries they can sustain, learn how these are diagnosed, and discover the intricate dance of treatment options.
Right, to get that aha moment about a critical part of our health.
Exactly. Whether you're just intensely curious about the human body's design, or maybe you've heard about an orbital injury and want to grasp the gravity and precision involved in its care, this deep dive is for you. We'll explore not just what happens, but really why it matters, and how medical science steps in to protect our vision.
Okay, so where should we start? The orbit itself.
Yeah, let's do that. We often focus on the eyeball, but the real silent guardian is the orbit, that bony socket. It's a truly fascinating structure.
It really is. Think of the orbit as like a quadrangular-based pyramid. Its tip points back towards the center of your skull.
A pyramid, okay.
Yeah, and while the eyeball itself, the globe, is roughly 7 cubic centimeters, the entire orbital vault averages about 30 cubic centimeters.
Wow, so quite a bit bigger than the eye.
Exactly. And what's absolutely crucial here is that even a slight shift in these bony walls, maybe just a millimeter or two, can significantly impact the globe's position and the overall orbital volume. It's a very finely tuned protective space.
And it's not just one big, solid bone forming that pyramid, is it?
No, not at all. It's actually, well, you could call it a symphony of 7 distinct bones working together.
7 bones.
Yes, bones like the maxillary zygomatic frontal, among others. They don't just form a protective socket, they also provide crucial anchor points for the muscles that move your eye and passages for vital cranial nerves and blood vessels. It's remarkable engineering, really.
Natural engineering at its best.
Indeed. And this bony sanctuary develops pretty quickly, too. About 85% of its growth is complete by age 5.
By age 5, wow.
Yeah. And it's typically fully formed sometime between 7 years old and puberty.
Okay, but here's where it gets really interesting, and I think this is key to understanding the injuries.
Mhm.
The orbital walls aren't uniformly strong, are they?
No, absolutely not. And that's actually a brilliant protective mechanism.
How so? Some parts are designed to be weaker.
Precisely. While the rims, the superior, lateral, and inferior edges you can actually feel around your eye socket, they're made of thick, robust cortical bone. Great protection from direct impacts.
Right, the strong outer edge.
But the bone just behind these thick rims can be incredibly thin. The medial wall, the one towards your nose, can be less than a millimeter thick.
Paper thin almost.
Literally. And the orbital floor, in its weakest part, can be as thin as just half a millimeter.
Okay, so if you take a blunt hit to the eye, those thinner areas, they act like the body's built-in airbags. They give way.
Exactly. That's a perfect way to put it. When blunt trauma causes a sudden spike in pressure inside the orbit, that pressure is often relieved because these thinner walls yield or fracture outwards.
Okay.
Orbital tissue, like fat or sometimes even muscle, can then push or herniate into the adjacent air-filled sinuses, usually the maxillary sinus below or the ethmoid sinuses medially.
So that outward expansion absorbs the shock.
Yes, it effectively acts as a shock absorber. It's this fascinating paradox of protection. The body uses a designed weakness as a strength, and that's why actual globe perforation, rupture of the eyeball itself, is surprisingly uncommon after many types of midfacial trauma.
That's amazing. But you mentioned a contrast with, say, frontal sinus fractures.
Right. Those fractures, often involving the thicker orbital roof, tend to be associated with much higher energy impacts. The forces involved can be so severe that they often lead to very serious eye injuries, and sometimes, sadly, are associated with injuries that aren't survivable. The airbag mechanism has its limits.
Got it. So the design protects against common impacts, but extreme force is a different story. Now let's quickly tour these walls because their specific weaknesses are important. The orbital floor.
Okay, the floor. It's primarily formed by the maxillary bone, part of your upper jaw. Its weakest point is located just medial to the infraorbital nerve canal.
And that location explains why blowout fractures are so common there.
Exactly. And that infraorbital nerve is important clinically, too. It provides sensation to your upper lip, the side of your nose, and your front upper teeth. Damage there can cause numbness.
Okay. And the medial wall, the one towards the nose.
That one's complex, made of several bones, including a very important, extremely thin bone called the lamina papyracea.
Lamina papyracea
Yeah.
sounds delicate.
It means paper plate. In Latin, it's often only 0.2 to 0.4 millimeters thick. Very fragile. This wall also has small openings, the ethmoidal foramina, which are critical landmarks for surgeons. They're close to vital brain structures and also near arteries, sometimes used to control serious nosebleeds.
High-stakes real estate in there. What about the lateral wall, the side?
That's typically the strongest wall, formed mainly by the cheekbone, the zygoma, and part of the sphenoid bone. But even though it's strong, it's still commonly fractured right where it meets the frontal bone at the frontozygomatic junction.
Still a common fracture site then.
Yes. And this wall also has a little bony bump called Whitnall's tubercle. It's tiny but critical. It's an anchor point for structures that help keep your eyelids stable and in the right position.
Fascinating detail. And finally, the roof, the top of the socket.
The orbital roof is mainly the frontal bone, your forehead bone. Directly above it lies the anterior cranial fossa, which holds part of your brain.
So very close to the brain.
Very close. And while the outer rim is thick and protective, the roof thins out considerably just behind that rim. Also, the frontal sinus, one of those air-filled cavities which develops around age 6, forms part of this roof structure.
Okay, so this intricate structure, with its strong points and designed weak points, it sets the stage for a whole variety of injuries, doesn't it?
It really does. What's fascinating, or maybe concerning, is the sheer variety of ways orbital trauma can manifest. From subtle shifts that might cause cosmetic issues later, to truly devastating damage affecting vision immediately.
And these aren't rare injuries, are they?
No, definitely not. Orbital fractures themselves account for maybe 4% to 16% of all facial fractures, but, and this is a key point, if you include fractures that involve the orbit, like cheekbone fractures, the ZMC type, and those complex midface fractures, the NOE type.
ZMC and NOE?
Right, zygomatic complex and naso-orbitoethmoid. If you include those, the number jumps way up. We're talking 30% to maybe even 55% of all facial fractures having some orbital component.
Wow, up to half or more. That's huge. So let's break down some common patterns. ZMC, the cheekbone fractures.
They are the most common type of facial fracture that involves the orbit. What typically happens is the cheekbone complex rotates.
Rotates.
Yeah, often around that frontozygomatic suture we mentioned. It gets pushed medially, downwards, and backwards. And in that process, the orbital floor usually takes the biggest hit, suffering the most disruption.
Which should make the eye look sunken or lower, right?
Exactly. Anophthalmos or hypoophthalmos. And then there are those NOE fractures.
The nasal-orbitoethmoid. They sound serious.
They result from severe blunt trauma right to the central part of the face, like the bridge of the nose area. Beyond the immediate bone damage, they often lead to significant cosmetic issues.
Like what?
Things like a flattened nasal bridge, making the nose look pushed in, and also a widening of the space between the inner corners of the eyes. That's called traumatic telecanthus.
Ah, traumatic telecanthus.
Yes, it creates a kind of flattened, widened appearance that can be quite noticeable. And crucially, NOE fractures carry a real risk of a cerebrospinal fluid leak, a CSF leak, if the fracture extends through the skull base and tears the dura, the membrane, around the brain.
Definitely serious implications there. Okay, these patterns show how forces spread. Now let's dive deeper into fractures within the orbit itself, the internal ones.
Right. Inside the orbit, we see a few basic patterns. You can have linear fractures. Here, the bone fragments generally stay aligned, but their angulation can change the orbital volume.
Increase or decrease it.
Exactly, which can lead to problems later, like that sunken eye appearance and ophthalmos. Sometimes these linear fractures, especially in kids with more elastic bone, can cause a trapdoor effect.
Trapdoor?
Yeah, the bone edges spring apart momentarily and then snap back, pinching and trapping soft tissues, often an eye muscle.
Ouch. Okay, and then blowout fractures. That's a term people might have heard.
Yes, definitely. Blowout fractures are the most common type of internal orbital fracture. They typically involve just a single wall, most often the anterior medial part of the orbital floor, sometimes the medial wall. Usually they're fairly small, less than 2 centimeters across.
And there are different types, pure versus impure.
That's right. A pure blowout is thought to result from direct trauma to the eyeball itself. The force transmits through the globe, causing a sudden spike in intraorbital pressure that blows out the thin floor or wall.
Okay, pressure from the inside out.
Exactly. An impure fracture involves both the orbital floor and the rim. This usually results from direct impact to the rim, compressing the structures.
Got it.
Now, here's a really surprising and important statistic. About 90% of patients with pure blowout fractures also have some associated injury to the globe.
90%.
Yes. Things like hyphema blood in the front chamber of the eye, or iridoplegia, paralysis of the iris, or even retinal hemorrhages.
Wow. That tells you these aren't just simple bone breaks. They're serious ocular events.
Absolutely. That 90% figure is startling. It underscores that any blowout fracture demands an immediate, thorough eye exam by an ophthalmologist. It's fundamentally a vision-threatening event.
Okay, that's crucial context. What about the opposite, blow-in fractures?
Blow-in fractures are less common. They typically involve the orbital roof, often occurring along with frontal sinus fractures. The bone fragments are pushed into the orbit instead of out.
And that can cause?
It can decrease orbital volume, pushing the eye forward, and sometimes leads to a condition called a pulsatile globe.
Pulsatile globe.
Yeah, it's a rhythmic pulsing, an in and out movement of the eye that's synchronous with the heartbeat caused by transmitted pressure from brain blood vessels.
That sounds unsettling. And complex fractures, I assume those are the worst.
Generally, yes. Complex fractures involve two or more orbital walls. They're often extensive, maybe larger than 2 centimeters, and frequently comminuted, meaning the bone is shattered into multiple small pieces.
Shattered, okay.
They often extend back towards the orbital apex, potentially involving the optic canal where the optic nerve runs. These are typically associated with severe high-energy trauma, like the kind you see in major car accidents or significant falls, often part of larger facial fracture patterns like the Fort 2 or the 3.
It's clear these injuries aren't just about broken bones. They can lead to a whole cascade of critical complications, some needing immediate attention. Let's talk about retrobulbar hematoma.
Yes, this is a true ocular emergency. Retrobulbar hematoma is bleeding behind the eye within that confined orbital space.
Like internal bleeding in the socket.
Exactly. And that space can expand easily, so the pressure builds up rapidly, like a pressure cooker. This pressure can compress the central retinal artery, which supplies blood to the retina or the optic nerve itself.
Cutting off blood supply or squeezing the nerve.
Precisely. Both can lead to permanent vision loss, even blindness, if not treated extremely quickly.
What are the signs? How do you know?
Key symptoms include ekthymos, the eye bulging forward, often accompanied by pain, very limited eye movement, and crucially, resistance when you try to gently push the eye back into the socket, what we call retropulsion. Sometimes the pupil might be dilated too.
And treatment is urgent.
Immediate. Often it requires a bedside procedure called a lateral canthotomy and cantholysis. It sounds dramatic, but it's a relatively simple surgical release of the outer corner of the eyelid structures to instantly relieve that pressure. Time is absolutely critical.
Wow, okay. True emergency.
Yeah.
Beyond bleeding, what about direct damage to the eye itself, like globe perforation?
A globe perforation or rupture means the eyeball wall itself is torn. It's often indicated by visible signs like an irregular, peaked, or teardrop-shaped pupil, which tends to point towards the site of the rupture.
The pupil shape gives away.
It can be a strong clue. Blunt trauma can cause a scleral rupture, a tear in the tough white outer layer, the sclera. This often happens at an anatomically weaker point, just behind where the eye muscles attach. Any suspected globe rupture requires urgent consultation with an ophthalmologist for surgical repair.
Okay. Now, you mentioned earlier that the body can sometimes react in surprising ways. What about sympathetic ophthalmia?
Ah, yes. This is rare, thankfully, but absolutely fascinating from an immunological perspective. Sympathetic ophthalmia is an autoimmune inflammatory response.
Autoimmune?
Yes, the body's immune system gets involved. But here's the twist. It occurs in the uninjured eye, usually weeks to months, typically within about 3 months, after a penetrating injury or surgery to the other eye.
So the good eye gets inflamed because the other one was hurt. How?
The thinking is that antigens, maybe from the uveal tract or retina of the injured eye, get exposed to the immune system. Then, T cells mistakenly recognize similar antigens in the healthy eye as foreign and attack them, causing inflammation. It's a case of mistaken identity by the immune system.
Incredible and scary. Let's shift focus to vision itself. Optic nerve injury. That directly threatens sight.
Right, absolutely. The optic nerve is the cable connecting the eye to the brain. Injury can result from direct trauma, bone fragments pressing on it in posterior orbital fractures or optic canal fractures, or even from swelling or bleeding compromising its blood supply.
And the symptoms.
Decreased visual acuity is the main one, ranging from mild blurring to complete blindness, what we call no light perception or NLP. Another key sign is diminished color vision, especially red desaturation, where red colors look washed out or faded. That can be an early, subtle sign.
Red desaturation, okay.
And doctors will also look for a relative afferent pupillary defect, or RAPD, where the pupil in the affected eye doesn't constrict as strongly to light compared to the healthy eye.
And treatment.
It often involves high-dose corticosteroids to reduce swelling and inflammation. If imaging confirms external compression of the nerve, like from a bone fragment, urgent surgical decompression might be necessary to relieve the pressure, but prognosis can be guarded.
All these issues, muscle problems, nerve damage, swelling, often lead to diplopia or double vision. What causes that after trauma?
Diplopia is very common. It can be monocular double vision seen with just one eye open, usually indicating a problem with the lens or cornea.
Okay, an issue within the eye itself.
Right. Or it can be binocular double vision only when both eyes are open, which disappears if you cover one eye. This is much more common after orbital trauma.
Now, what causes the binocular kind?
Well, the most frequent cause initially is simply orbital edema and hematoma, swelling and bruising within the orbit. This usually disrupts the fine coordination of the eye muscles and typically resolves as the swelling goes down, often within 7 to 10 days.
So sometimes it just gets better on its own?
Often, yes. But persistent diplopia can be due to mechanical restriction where muscle movement is physically blocked, either by entrapment in a fracture, like that trapdoor effect, or later by scarring. Or it could be neurogenic, resulting from damage to the cranial nerves that control the eye muscles.
How do doctors tell the difference between trapped muscle and nerve damage?
A key test is the forced duction test. After numbing the eye, the doctor gently tries to move the eyeball with forceps. If there's resistance, it suggests a mechanical problem, like entrapment. If the eye moves freely, the problem is more likely nerve-related weakness or paralysis.
That makes sense. And those trapdoor fractures we mentioned, especially in kids, they're a big deal for diplopia.
A huge deal. Because children's bones are more elastic, they can trap a muscle without necessarily having a large obvious fracture on CT. This can cause immediate and severe restriction, often preventing the eye from looking up or down properly.
And that needs quick action.
Extremely quick. Urgent surgical intervention, often within 12, maybe 24 hours at most, is needed to release the trapped muscle. Waiting longer risks ischemia, lack of blood flow to the muscle, and subsequent fibrosis or scarring, which can lead to permanent limitation of movement. It's called Volkmann's contracture in other contexts.
Wow, time is critical there too.
Absolutely. And there's another interesting connection. Muscle entrapment can sometimes trigger the oculocardiac reflex.
Oculocardiac reflex.
Yeah, traction or pressure on the eye muscles, particularly the medial or inferior rectus if trapped, can stimulate the vagus nerve, causing a sudden drop in heart rate, bradycardia, and sometimes nausea or even vomiting. It's another sign surgeons look out for.
Fascinating how interconnected everything is. Okay, this raises the big question. With such a complex range of potential injuries, how do doctors navigate it all to ensure the best outcome for both vision and function?
It absolutely starts with a meticulous, systematic clinical examination. Even if the injuries look severe, you have to follow a structured approach.
What does that involve?
Well, you methodically check visual acuity using a standard eye chart. You carefully inspect the eyelids and the whole periorbital region for swelling, cuts, bruising, signs of canthal tendon disruption, that anchor point we mentioned, or tear duct injury.
Looking for all the external signs.
Exactly. Then, assessing extraocular movements is critical. Checking how well the eyes move in all directions, specifically asking about double vision in different gazes, and performing that forced duction test if restriction is suspected.
Testing the mechanics.
Right. Then pupillary responses, checking size, shape, symmetry, reaction to light, looking for that RAPD we discussed, and noting any irregularity like that teardrop shape suggesting perforation.
Checking the nerve pathways.
Precisely. Measuring globe position is also key, is the eye sunken enophthalmos or bulging exophthalmos. Testing visual fields for peripheral vision loss. Doing a fundoscopic exam to look at the retina and optic nerve head inside the eye for hemorrhages or detachment.
Looking inside the eye itself?
Yes. Measuring intraocular pressure with tonometry. Using a slit lamp microscope for a highly magnified view of the front of the eye cornea, anterior chamber, looking for blood, hyphema. And finally, gently palpating the bony rims, feeling for steps or irregularities indicating fractures, checking for crepitus, a crackling sensation from trapped air, and testing facial sensation like that infraorbital nerve.
That's incredibly thorough.
It has to be. You piece together all these findings, but often the clinical exam points you towards needing definitive imaging.
And that's where technology like CT scans comes in.
Absolutely. The CT scan, computed tomography, is really the gold standard for acute orbital injuries.
Gold standard, okay.
A non-contrasted CT, meaning no IV dye is needed initially, is the primary tool for evaluating blunt or penetrating trauma and locating most foreign bodies. It gives incredibly detailed cross-sectional images of the bone.
So you can see the fracture lines clearly.
Exactly. You can see the fracture patterns, assess displacement, and measure changes in orbital volume. Getting images in both axial, horizontal, and coronal vertical planes is crucial. And if you suspect an optic canal fracture, you need very fine cuts, maybe 1 or 1.5 millimeters thick, to visualize that tiny channel.
So CT is king for bone and most foreign objects. What about soft tissues or things CT might miss?
That's where MRI, magnetic resonance imaging, can be very useful. It's superior for visualizing soft tissue injury like muscle swelling or damage and confirming muscle entrapment.
Better for muscles and soft bits.
Yes. But there's a critical safety point with MRI. You absolutely must screen for any possible ferromagnetic foreign bodies before the scan.
Magnetic metal fragments.
Right. The powerful magnet in the MRI scanner could potentially move a metallic fragment, causing devastating further injury. So screening is essential. MRI is also great for identifying radiolucent foreign bodies, things X-rays or CTs don't see well, like wood, which can sometimes look like air on a CT, and it can help assess persistent orbital emphysema, that trapped air.
Okay, so CT first, maybe MRI for specific questions if it's safe. Any other imaging tools?
Ophthalmic ultrasonography can be useful too. It's inexpensive, non-invasive, uses sound waves. It can be good for detecting certain radiolucent foreign bodies or things in the front part of the eye, though it's less effective for deep orbital injuries near the apex. Color Doppler ultrasound can even evaluate blood flow in orbital vessels.
So a range of tools, depending on the situation. Once all this information, clinical exam, imaging is gathered, how are treatment decisions made? It sounds like it's not always immediate surgery.
That's right. The standard of care has really evolved. Decades ago, some advocated for fixing almost every fracture immediately, while others leaned towards just observing. Modern practice is much more nuanced. It's a selective approach.
Selective based on what?
Primarily based on functional deficits, meaning problems with vision or eye movement, and significant cosmetic deformities.
Okay, let's break that down. When is surgery functionally urgent?
Urgent intervention, like within 12 hours, is really reserved for those cases of clear mechanical restriction of eye movement, confirmed by a positive force reduction test, and CT evidence of a trapdoor fracture or obvious muscle incarceration, especially in kids.
To prevent that permanent muscle damage.
Exactly. Early intervention, maybe within a week or two, is usually indicated for persistent diplopia within the central 30 degrees of gaze, the range you use for most daily activities like reading. Also, significant visual loss from optic nerve compression requires urgent surgical decompression, often within 12 to 24 hours, sometimes endoscopically through the nose.
Okay, so fixing vision or movement problems. What about cosmetic reasons?
Surgery is often recommended for cosmetic reasons if there's significant anophthalmos or hypoophthalmos, the eye being sunk in or sitting lower, usually by about 2 to 3 millimeters or more.
Noticeable asymmetry.
Right. And this has to be due to increased bony orbital volume from the fracture and not just temporary swelling or leader fat atrophy. Early repair within the first few weeks generally gives the best cosmetic outcome for volume issues. Also, large orbital floor defects, say covering more than half the floor area with obvious prolapse of orbital contents into the sinus, usually warrant repair to prevent late sinking of the eye.
So, when might observation be the right call?
Observation, often for about 2 weeks initially, is a very reasonable approach for patients with only mild double vision or restriction or smaller floor defects, less than 50%, without any clinical or CT signs of tissue entrapment.
Give it time to settle.
Exactly. Often, the initial double vision is just due to swelling and it resolves. Eye movement exercises and sometimes a short course of oral corticosteroids can help reduce edema during this period, but there's a time limit.
Ooh.
Unnecessary delays in surgery, pushing it beyond maybe 4 to 6 weeks, make the repair significantly harder. Scar tissue forms, muscles can shorten, and repositioning everything correctly becomes much more challenging.
So there's a window for optimal repair.
There definitely seems to be. Okay, so if surgery is needed, how do surgeons actually approach rebuilding this delicate fortress?
Yeah, what are the strategies and materials?
Well, first, there's sequencing. If there are other facial fractures, like the zygoma or NOE fractures, surgeons generally fixate those first to reestablish the outer orbital framework. Then they address the internal orbital wall defects.
Rebuild the frame, then the walls. Makes sense. How do they get access?
Access depends on which walls need repair. For the inferior or lateral orbit, the floor and side wall incisions hidden along the lower eyelid lash line, subciliary, or more commonly now, inside the lower eyelid, transconjunctival, are very popular. They give great access with excellent cosmetic results.
Hidden incisions.
Yeah. The transconjunctival approach can be extended laterally if needed. For the superior or medial walls, incisions might be placed in the eyebrow or an upper eyelid crease. For really complex fractures involving multiple walls, the roof, or the zygomatic arch, a coronal incision might be used.
Coronal, across the scalp.
Yes, hidden within the hairline. It sounds extensive, but it provides wide, unparalleled access for complex reconstructions. For the medial wall specifically, approaches through the side of the nose, or again, for better cosmetics, through the inner corner of the eye near the tear duct, transcaruncular, are options. And increasingly, endoscopic approaches are gaining popularity.
Through the sinuses.
Exactly. For orbital floor repair, surgeons can sometimes go through the maxillary sinus using small cameras and instruments, completely avoiding external skin incisions.
Wow. Okay, once they have access, what do they use to rebuild the broken walls? Like scaffolding.
That's a good way to think about it. Surgeons have several material options. Porous polyethylene implants are very common. They're biocompatible, meaning the body accepts them well, they don't resorb over time, they're somewhat flexible, and importantly, tissue can grow into the pores, which helps anchor the implant and reduces migration risk.
So it integrates well.
It does, often secured with just a tiny titanium screw. For more severe comminuted injuries or when the implant needs to span a large gap and provide more rigid support, titanium mesh is often used. It's strong and can be precisely contoured. Sometimes it's covered with porous polyethylene or even a bone graft to prevent scar tissue from adhering directly to the mesh.
Bone grafts from
Yep.
the patient.
Yes, autogenous bone grafts, taking bone from the patient's own body, like the skull, calvarium, or hip iliac crest, can be used either alone or sometimes placed over mesh for very large defects. And for very small defects, sometimes just a temporary barrier like absorbable gelatin film is used, though it offers little structural support.
So different materials for different jobs. What's the main goal during the reconstruction?
The absolute paramount goal is restoring the normal bony orbital volume and contour as accurately as possible. This is crucial for preventing late anaphthamos or diplopia.
Getting the volume right.
Precisely. And surgeons perform that forced duction test again during the operation after placing the implant or graft to make absolutely sure no tissue is being pinched or impinged upon.
Checking for freedom of movement right then and there.
Exactly. And for severe defects where significant sinking is anticipated, surgeons might even aim for a slight overcorrection initially, making the eye seem slightly prominent, knowing that post-operative swelling will resolve and tissues will settle, hopefully into the perfect final position.
Interesting. Planning for the settling. You also mentioned traumatic telecanthus earlier, with NOE fractures that widening between the eyes. How is that fixed? It sounds precise.
It requires very precise techniques. The key is accurately reattaching the medial Campbell tendon, the structure that holds the inner corner of the eyelid against the bone. Often, this involves specialized transnasal wiring.
Wiring through the nose.
Essentially, yes. A fine stainless steel wire, often a double loop, might be passed through drill holes in the nasal bone from the opposite side, looped around the detached tendon or the bone fragment it's attached to, and then tightened to pull the canthus medially back into its correct anatomical position and secure it firmly. It's intricate work.
Definitely sounds like it demands precision.
It really does. And that level of precision is why advanced planning tools are becoming more common for complex cases. Things like stereolithographic modeling, creating 3D printed models of the patient's skull from CT data computer-assisted surgical planning, and even intraoperative navigation systems like GPS for surgery are increasingly used to help surgeons achieve the most accurate reconstruction possible.
Amazing how technology aids that surgical artistry.
It truly enhances our ability to restore both form and function.
Well, we've certainly journeyed through the intricate anatomy of the orbit, explored the diverse and sometimes surprising ways it can be injured,
Hmm.
and really marveled at the diagnostic tools and the surgical precision required to restore both function and aesthetics.
Yeah, from the body's clever airbag design in the fin walls.
Right, to the meticulous recreation of orbital volume with implants and grafts, and that sophisticated re-anchoring of structures like the canthal tendon.
It's clear that protecting and restoring our vision involves this profound blend of, well, science, engineering, art, and incredible surgical skill.
Absolutely. So considering this intricate balance within our orbits, this delicate fortress protecting our sight, what new appreciation do you, our listeners, have for the everyday wonder of vision and that bony protection, and perhaps for the incredible surgical artistry required when that delicate balance is disrupted? Something to think about.